Good evening, everyone, and welcome to Heart of the Matter, a virtual discussion on cardiovascular health and diabetes. I am Dr. Erin Dixon Prince, co-chair of the Physical and Mental Health Committee of the Houston Alumnae Chapter of Delta Sigma Theta Sorority Incorporated. April is National Minority Health Month. This annual observance builds awareness about the health disparities that persist among racial and ethnic minority and American Indian and Alaska Native populations and encourages everyone to take action to end these inequities. This year's theme for Minority Health Month is Be the Source for Better Health, improving health outcomes through our cultures, communities, and connections. Delta Sigma Theta Sorority Incorporated has prioritized collaborating with charitable partners that support important domestic and global concerns, including health disparities. Delta Sigma Theta Sorority Incorporated has identified the American Diabetes Association as a charitable partner, whose mission it is to prevent and cure diabetes and improve the lives of all people affected by diabetes. We are excited to have a representative with the ADA to educate and empower us regarding this disease that disproportionately affects our community. Tonight, through this presentation, we hope to address one of the important social determinants of health, healthcare access and quality, by offering education, access to healthcare providers such as our featured panelist and cardiologist, Dr. Prince, and introduce evidence-based and community resources to improve health and prevent disease in our community where health disparities exist. Thank you for joining us this evening. And with that, I will turn it over for a more formal welcome from the president of the Houston Alumnae Chapter of Delta Sigma Theta Sorority Incorporated, Karen Durso.
Good evening. My name is Karen Durso, and I am president of the Houston Alumnae Chapter of Delta Sigma Theta. Tonight, we are hosting this webinar in honor of National Minority Health Month. I know our experts tonight will share the statistics on heart disease and diabetes and how they disproportionately impact the African American community. But as a woman in the later stages of life, I want to know more about how both diabetes and heart disease can be avoided or at least controlled to ensure I have a good quality of life in my retirement. To the younger members of our audience, I hope you will also take advantage of learning how you can avoid being a victim of heart disease or diabetes. So please listen, ask questions, and make note of the potential life-saving advice our experts will provide. Thank you and enjoy the webinar. Erin, back to you.
Thank you. So I have the esteemed pleasure of introducing my husband, Dr. Marloe Prince. Dr. Prince is a highly trained, patient-centered, and attentive cardiologist, specializing in general and interventional cardiology. His interests include structural heart disease, peripheral vascular disease, coronary artery disease, and preventative heart disease. Dr. Prince was born and raised in Tulsa, Oklahoma, and attended the University of Oklahoma. He then attended Meharry Medical College in Nashville, Tennessee for medical school and the Jewish Hospital in Cincinnati, Ohio for internal medicine residency. His cardiology, interventional cardiology, and structural cardiology training were all completed at the Ochsner Clinic in New Orleans, Louisiana. Dr. Prince has published numerous manuscripts on atherosclerosis, revascularization procedures, lipid disorders, and also created scholarly book projects and chapters. He is board certified in internal medicine, cardiology, and interventional cardiology. He practices using the latest minimally invasive techniques. His expertise includes advanced coronary intervention, peripheral vascular disease, including carotid stenting, renal stenting, and chronic limb ischemia, and also structural heart disease procedures, including aortic valve replacements, mitral clips, Watchman procedures, atrial septal defect closures, and PFO closures. Dr. Prince has also received numerous awards, including the Best Rookie Award, Physician of the Quarter in 2024, and Physician Choice Award 2024, which was he was elected by his peers. Before he begins his presentation, I would like all audience members to know that you may use the Q&A pane to submit questions for Dr. Prince. He will provide a brief Q&A at the end of his presentation for about 5 minutes. So without further ado, take it away, Dr. Prince.
All right. Thank you for the warm introduction, and thank you to Delta Sigma Theta for allowing me to give this presentation today. So I'll be talking about African American heart health. Some of the objectives of this presentation will be, I'll give a little background of the heart and how it functions. We will talk about heart disease and how it disproportionately affects African Americans. We'll talk about some of the disparities affecting African Americans, risk factors for heart disease, and ways to improve our risk of heart health. So the heart is a very amazing organ. In a single day, it beats about 100,000 times and pumps about 2,000 gallons of blood throughout your body. It carries oxygen and nutrients to the organs so they get what they need in order to work properly. Your heart is vital to health and nearly everything that goes on in your body. So the heart structure. The heart is a muscular cone-shaped organ. It's about the size of a fist. It has two upper chambers. These are called the atrium, and then two lower chambers, and these are called the ventricles. Blood usually enters the heart through the right atrium, where it has deoxygenated blood. This travels through the right atrium, and you see here on the picture on the right, travels down into the right ventricle, and then to the lung arteries, where it becomes oxygenated. It then pumps to the right, or to the left atrium, where it's oxygenated, and then the left ventricle pumps this oxygenated blood throughout the entire body. So what is heart disease? Cardiovascular disease is basically just an umbrella term for all types of diseases that affect the heart or the blood vessels. It basically just is a catch-all phrase for a variety of problems that affect the heart structure and how it works. The most common type of heart disease in the Western Hemisphere is coronary artery disease, which is where the heart arteries become clogged, usually with cholesterol plaque. What I want to draw your attention to here is the signs and symptoms of a heart attack. Here on the left side, men typically read the textbook. So they have chest pain, pain in the shortness of breath, pain in the back or neck, jaw area. Sometimes they can have sweating, pain in the shoulder, or indigestion. On the right side, women typically present quite a bit differently than men. Oftentimes, they don't even have chest pain. I've seen oftentimes where women come in with a heart attack, and they may just have neck pain or just very vague symptoms. So here on the right, you see women have some shortness of breath. Sometimes they have pain in the shoulder, tiredness, trouble sleeping, anxiety, sweating, indigestion. Knowing the facts. A heart attack or a stroke may seem sudden, but the truth of the matter is that heart disease happens over many years. It often begins when you're very young. So we've got to do a better job at an early age taking care of ourselves. Stress and anxiety also play a role in heart disease. And And so preventing heart disease is important at any age. Heart disease in African Americans. Racial and ethnic disparities in cardiovascular disease are still present in the US. Across every metric, African Americans have poor cardiovascular health that is much worse than whites and a higher cardiovascular mortality rate than whites. And little has changed since 2005. So why do these disparities matter? Cardiovascular disease is the #1 killer of American women, African Americans, and Latinos. And by the year of 2050, people from minority populations are expected to represent nearly 50% of the US population. Even when minorities have insurance and are at the same social class, we often receive lower quality of care than our counterparts. While some progress has been made in the primary care realm, recent studies suggest that little progress has been made in racial and ethnic disparities in cardiovascular care. Why do these disparities exist? Some of them are patient related. Patients have preferences. Sometimes they don't want to see the doctor. Sometimes they don't want to, receive treatment. Care-seeking behaviors and attitudes. Like I said, sometimes people just don't want to show up to the doctor, or they're in denial of their, comorbidities. Healthcare system related. So some people live way far away from the hospital, or they're not able to get to the hospital or to a clinic to receive care. There have been changes in finances and the delivery of healthcare services. Some people don't have insurance. Lack of interpretation and translation services. So sometimes doctors and other physicians talk way over the patient's heads. So they don't understand what's actually going on. And so that can be a barrier to treatment. And then there are time pressures of physicians. Oftentimes doctors or, healthcare workers have to see patients in a timely fashion. Usually 10 to 15 minutes is all you have to see a patient, and you're expected to see another patient thereafter. And then there are provider-related disparities, which include bias, clinical uncertainty. Sometimes the doctor doesn't know what's going on. And then beliefs, stereotypes about the behavior or health of a minority. So whenever we talk about cardiovascular disease, there are modifiable risk factors. These are things that you can change, such as weight, your diet, exercise, things like that. And then there are non-modifiable risk factors. These are things that you can't change, such as your family history. First, I'll talk about the modifiable risk factors. These, again, are the things that we can change. Hypertension is one. Diabetes, high cholesterol, being overweight, poor diet, physical inactivity, heavy drinking, not getting enough sleep, sleep apnea, smoking, and stress. So hypertension. This is likely the largest risk to cardiovascular disease in African Americans. Over 40% of men and almost 45% of women over the age of 20 have hypertension in the United States. This is about 12% higher than whites and Hispanic. Even though African Americans are more likely to be aware of hypertension and have it treated, despite knowing and having it treated less often, half are controlled on their current medicines. So what is a good blood pressure? So usually, if you look here in the middle of the slide, we want to have our blood pressure less than 130, the top number, which is the systolic, over 80. So less than that is the ideal blood pressure. Next, I'll talk about diabetes. So diabetes can cause visual impairment, kidney disease, and peripheral arterial disease. Peripheral arterial disease is basically just blockages in the arteries which exist outside of the heart. And this is near and dear to me because it oftentimes can lead to amputation, which is very, very apparent, especially in the African American community, because a lot of people don't know that there are options that can be done, and they, just end up being offered an amputation. So there are two types of diabetes, type 1 and type 2. Overwhelming majority of people have type 2 diabetes. About 20% of African Americans in the US have diabetes, which is about double of whites. And about 37% of these 20% are not diagnosed. There has been about a threefold increase in diabetes since the late 80s. And not only are African Americans less likely to know that they have diabetes, but they're also less likely to achieve adequate control. And so the goal, hemoglobin A1C, is less than 7%. So what is hemoglobin A1C? This is basically a measurement of your blood sugar over the past 3 months. And so usually it's a blood sample that can be taken by your doctor, and we can measure and see how good your sugar has been over over a 3-month period. High cholesterol is also a modifiable risk factor. And despite African Americans having higher cardiovascular disease than whites, cholesterol levels are actually lower than whites, which tells us that there are other lipid particles present in the blood that the cholesterol panel doesn't measure. Some of these can be lipoprotein A or A lipoproteins. So usually I aim to get the LDL, which is the bad cholesterol. There are two different components of cholesterol. You have HDL, which is the good cholesterol, and LDL, which is the bad cholesterol. And I usually like to get the LDL as low as possible, especially if somebody has cardiovascular disease. And I usually target a level of less than 50. Obesity. So obesity is defined as body mass index of greater than 30. This isn't always the best measurement to determine if somebody is obese, because oftentimes people can have a higher muscle mass and still be deemed as obese. It basically pertains to the fat distribution and body compensation or composition, which are much more accurate in telling the cardiac risk of a patient. Among patients over 20 years of age, African American women have the highest rate of obesity at about 58%. African American men have obesity rate of about 37%, and white men have an obesity rate of 34%. And as you see here, white women have an obesity rate of 33%. Studies show that cultural attitudes in African Americans favor larger body size in women, which may play a role in these obesity characteristics. An unhealthy diet. So here are some things that we can do in terms of the diet. Limit sugary drinks, sweets, fatty meats, limiting salty or highly processed foods, avoiding partially hydrogenated oils or tropical oils,